Thank you, Andy and Sally, for inviting me today. I've given this talk before and lost before, so and you know when the next talk's on tandem transplant, you're really up against it. I would like to say that this is a really important debate and it should never go away, because I think transplant is quite a horrible procedure, and I can't believe that everyone's quality of life goes back to normal. Here are my disclosures. So my argument is that the survival benefit with a transplant is questionable, that we still need to be asking this question, and it shouldn't go away really, because we have monoclonal antibodies now, daratumumab up front, and the last trials didn't have any monoclonal antibodies. I would argue that there are longer-term consequences of transplant which we tend to ignore, particularly on T cells and bone marrow. And then, of course, we've heard all the data on the Maya data, which looks fantastic. And also, we should probably be thinking more about genetics and MRD, frailty, when we're thinking about transplant more than ever before. So these are the last studies which Kerry's discussed. They're interesting studies in that one was done in America and one was done in France. The French got their act together and they did it much quicker, so there was quite a bit of delay with the American data coming out. They're identical apart from the length of maintenance, but this is really important when you look at the PFS results, because they're very different. So the French just gave 12 months of LEN because they were scared then about secondary malignancies. But the Americans gave continuous LEN. Very similar studies, RVD, no antibodies, no DARA. This is the last data that we've got. And sure enough, there's a PFS benefit. I'm not going to argue against that. But if you look at this, there's a huge difference in the PFS in the American study compared to the French study. And that's because they're on LEN continuously. And a lot of the benefit, I think, from a transplant is probably due to continuous LEN, and we should remember that really. But what about OS? No benefit, no obvious benefit in survival. So we're putting patients through this horrible procedure, and are we really giving them a survival benefit? Questionable. And this is a fault of the human race, that we only look at positive trials. So this is when I was a registrar back in the 90s. We had all these transplant studies. They're all historical. But interesting, the ones that get quoted are the MRC7 and the IFM trials, which showed positive results. And then all these negative trials, of which are a lot, just get ignored. And I think this is a shame, really, that you have to have a positive result to get into a good journal. If you have a negative result, you'd get nowhere in life. And I think that's very wrong. And a lot of these trials were good trials, you know, HOVON, etc., Pathema. So I'd argue there's no survival benefit. And then we need to keep asking the question. So the deeper responses we have, the more MRD negativity we have after induction regimens, the longer patients are going to go before they relapse. And you have to question what's the additional value of a transplant if you've got hugely effective induction regimens. So we don't know whether the addition of DARA really influences the benefit of a transplant, doing an additional transplant or not. But of course, we've not just got DARA, we've got BiTEs and we've got CAR T cells. So yes, I am going to challenge Kerry and say, should we be having an arm that doesn't have a transplant in it? Should we be using novel therapies sensibly to try and avoid having to do a transplant? So there are trials of CAR T cell therapy versus transplant, but there'll also be BiTE antibodies coming on earlier on in the disease, without doubt. You know, 60% response rates in the multiple relapse setting. So these treatments are hugely effective with very deep responses. And can we replace transplantation? So we have to keep asking the question, We can't just say it's the same old, same old. It isn't. So the obvious one is toxicity, and it's significant for a lot of patients. A lot of patients will not want to have a tandem transplant. We all know about the acute toxicity. It's fairly horrible. But what about the longer-term toxicity? Marrow recovery isn't always great. We know that there's a secondary MDS signal with high doses of melphalan. And we need to be mindful of the fact that patients are living for longer, and you see secondary cancers over time. So it may be if patients start living longer than 10 years, 15 years, we're going to see more secondary MDS. But what about the T cells? What happens to your T cell repertoire when you have a stem cell transplant? It's not great. And these are the same T cells that we're expecting to be used for CAR T cell therapy or immunotherapy and by antibodies. And this just shows the acute toxicity, which we all know. This is the IFM study. So obviously in the transplant arm, you're getting much more mucositis, gut toxicity, etc. during the transplant period. So the next point has already been discussed in some detail by Kirsty. So if you look at myeloma 11 trial, so they have the intensive trial and the non-intensive arm, and this is the age range. There's a huge overlap, really from sort of the age of about 62 to the early 70s. So in other words, this patient age group is a grey zone. Some patients go down the transplant route, others don't. And this is really, I think this is probably the most important part of my talk. It's also alluding to what Kirsty says. We need to be thinking about this patient group in particular with better induction regimens that we've got now. Should we be really transplanting this group of patients where we're a bit uncertain when they've got some comorbidities, where we're a little bit uncertain about how they're going to get on? And we know that older patients don't do so well. They get excluded from a lot of the transplant trials, as Kirsty alluded to. So there's less data about older patients. But now we have fantastic induction regimens for the older patient. We have Dara-Lendex, and this is unprecedented. So Dara-Lendex, median PFS is 62 months. That's absolutely amazing. So there's something about a combination of an IMiD and an anti-CD38. So should you really be transplanting that patient in their early 70s where you're a bit unsure about their fitness, when you've got this regimen that's going to probably give them a very long treatment, a break from their disease coming back? And there's a survival benefit when you add in Dara as well. Sure, you can argue about day unit time. We do have an outreach service. I phone my patients. I send the LEN out. It can work. You know, this is the way I think we probably need to go. Our capacity is quite limited in our day unit with everything going on, so it really works for us. And the main toxicity that we're finding is neutropenia. We can manage that, be very proactive with GCSF, and you can manage it. But the other thing that we've always done is we've really historically ignored genetics, we've ignored MRD, and maybe we should be thinking more about using genetics and MRD to make our decisions around transplant as well, which we haven't really been doing probably enough. And MRD is very, very powerful prognostically, way better than complete remission or VGPR. And it's going to tell us something about the expected outcome for that patient. There's lots of meta-analysis showing this now. So if you compare MRD to CR, it's way better at predicting longer-term outcomes. So should we be looking, and Kerry alluded to this, and I agree with her, you know, should we be looking at responses and making decisions about transplant a bit later on, and also reassessing patients' fitness and frailty after some sort of induction, and maybe not making the decision from day one. And I think Sequential MRD results as well are particularly powerful, and we saw this in Mayo. So Mayo, about a third of patients are getting MRD negative. That's unprecedented. And these patients who stay MRD negative have really great longer-term outcomes. So maybe we should be thinking about using MRD as a way of thinking about whether we should transplant people or not, particularly in that grey zone, whatever induction regimen we're using. And of course, MRD is a bone marrow, but maybe eventually it'll get replaced by serum tests or some other way of measuring it. And we can't ignore genetics as well. So Matthew's going to talk about tandem transplants. We can't just lump all these patients the same. Genetics, I think, high-risk patients may be the ones where they do need a transplant. I don't know. But that should be part of the data that we're looking at when we make these decisions. So in short, I know I'm going to lose this debate, but it's a really important question. It never goes away. Don't think we've solved it. We haven't. The better induction regimens, the deeper MRD, the less likely it is that a transplant's going to be adding that much, except toxicity. Is it really doing a lot for our T cells? And we have great induction regimens for the non-intensive arm for patients now. And should we be thinking more cleverly about how we use a transplant as well? Thank you.
Okay, any questions in the room for either Kerry or Guy? Okay, not seeing any hands at the moment. I'm going to show you that vote again and see whether either of them have been able to swing the needle with regards to what you would do with the patient that was presented right at the beginning. I don't know if we've got that slide available. There's movement happening at the back. So I'm going to make the two results incomparable by telling you, please don't vote for option 1, whereby you don't do anything until you know how the patient is. So if we could push you into the middle 4 options, that would be great. And I'll do some bodgy statistics at the end and see whether anyone's won. So options 2 to 5 are your options for this patient, if you recall the case. Presenting with acute kidney injury, although you may not need to worry about that. Kirsty presented that data to us about transplant in patients with kidney disease. I think we've still got some votes coming in. Okay, waiting for a thumbs up, yeah. And the winner is, oh dear, yeah, I think we actually managed to push some people into other options, actually, it seems. So I was going to split up the 50% of people who voted for option 1 and add them 25% each to DVTD and DRD, but even with that measure, I think the transplant arm has won there. But Guy, you've managed to convince some people into DRD, and into a Velcade-based triplet as well. Some people have despaired and gone for a clinical trial. So overall, I think that's been a highly successful debate. And I think so important, I mean, this is, if you look around the meetings going on around the country, everybody's debating this issue. And the fact that you said at the beginning it's not going to go away. So such an interesting and important question. And I think the fact that so many people are debating it shows us that we don't really know what the right answer is in a lot of these cases. But we're going to have more opportunities to ask questions after the coffee break. We're going to have a talk on tandem transplant and then a panel discussion where you can ask all your burning questions. So we're a few minutes behind. We're going to come back at past rather than 25 past for those who are online, and we'll see you then.